Good afternoon, everyone. My name's Claire Fraser and my co-chair here is Dr Anu Matthew. We're going to start the session on time and try and keep everything running smoothly. But first off, I'd like to read out the acknowledgement of country. The Royal Australian and New Zealand College of Ophthalmologists members and participating guests wish to acknowledge the Aboriginal and Torres Strait Islander peoples of the country, sovereign custodians of country. We acknowledge their continuing presence and their contributions made to the college and the communities we work in. We respect the past elders and communities and will continue to live, work and interact in a respectful manner with present and future elders and communities. The RANZCO Reconciliation Action Plan reflects the message of its First Nations engagement. So welcome everyone to the session. Our speakers have got 5 minutes with 2 minutes question time. And I would ask that the speaker who's speaking next will go to the alternate podium from the one that's currently being used. This one has a clicker for forwarding. This one has a mouse. And please submit your questions through the app and we'll ask them to our speakers. So it's my great honour to welcome our very first speaker for the session, Dr Ella Berry, who's going to talk to us about body mass index and glaucomatous outcomes. Welcome, Ella.
Thank you. Good afternoon and thank you for attending and thank you to the organisers for giving me the opportunity to present in this session. I'm Ella and my talk today is on body mass index and its associations with glaucomatous outcomes in 3 cohorts. I have no financial disclosures. Primary open-angle glaucoma is characterised by retinal ganglion cell degeneration. Oh.
I've got to do it from memory.
Yeah. So primary open-angle glaucoma is characterised by retinal ganglion cell degeneration, where the most clinically modifiable risk factor is IOP. There's a growing body of evidence that additional systemic risk factors may be implicated in disease progression. The association between BMI and POAG is complex, with multiple studies demonstrating a higher BMI is protective against POAG. Conversely, an elevated BMI has been associated with higher IOP in large population-based studies. So we've investigated the association between BMI and POAG in both glaucomatous and population-based cohorts. And just a reminder, BMI is weight divided by height squared. Progresso is a longitudinal clinical and genetic study aimed at predicting the risk factors for the development and progression of glaucoma. Participants have 6 monthly Humphrey visual fields and OCT scans of the macular ganglion cell in a plexiform layer and of the RNFL. Using the change in mean deviation, rates of visual field progression were retrospectively calculated from progressor enrolment to the date of their BMI measurement. The Canadian Longitudinal Study of Aging is a randomly sampled national longitudinal cohort study of over 50,000 participants in Canada. At enrolment, height, weight and a retinal fundus image where the vertical cup-to-disc ratio of participants was taken. 3 years later, participants underwent a further retinal fundus imaging. We looked at the association between baseline BMI and the 3-year change in the VCDR. And then finally, the UK Biobank is a phenotypic and genotypic population-based study in the UK. We looked at the association of BMI and both the cross-sectional VCDR and glaucoma diagnosis. For the progressive data collection, at a routine follow-up review, I measured the BMI or the height and weight of 471 progressor participants. These are participants who are glaucoma suspects or have early manifest disease. Following exclusions for the association between BMI and longitudinal mean deviation was assessed on 693 eyes from 355 participants. Eyes were characterised as either fast progressors, slow progressors or stable based on their visual field change. Box and whisker plots show the BMI for each group, with stable cases being the red, slow progressors the green and stable the blue. And fast progressors the blue, sorry. P derived from a student's t-test compared fast progressors to stable cases. Panel A is demonstrating fast progressing cases had a 2.5 unit lower BMI than stable cases. This result was replicated in a sub-analysis of early manifest glaucoma cases as demonstrated in panel B. Next, we looked at the association between BMI and structural progression in the Canadian longitudinal study of ageing. Progression was defined as a change in VCDR between enrolment and their 3-year review. Analysis was performed using a multivariable linear regression and included covariates of age, gender, IOP, and baseline VCDR. Analysis was performed, a lower BMI was associated with greater VCDR change over this 3-year period. And then finally, looking at the UK Biobank, a further analysis explored the correlation between BMI and cross-sectional artificial intelligence-derived VCDR. A lower BMI was associated with a greater VCDR, cross-sectional VCDR. Subsequent analysis then correlated BMI with glaucoma diagnosis, first from specialist grading retinal fundus image and then using the ICD-10 diagnosis criteria for glaucoma. A lower BMI was associated with a greater risk of glaucoma diagnosis in both these groups. This multi-cohort study combined glaucomatous and normative individuals from 3 separate cohorts to present novel associations between body mass index and longitudinal visual field and structural progression. In all 3 cohorts, a lower BMI was correlated with poorer longitudinal and cross-sectional glaucomatous outcomes. These findings of this study reaffirm previous cross-sectional literature describing this phenomenon and highlight the need for further research into the etiology of these associations. And it does pose the question, these study results have some interesting thoughts on the relationship between BMI, POAG and IOP, with the paradox association of higher BMI being protective against POAG, despite large population studies demonstrating a higher BMI is correlated with a higher IOP, that being the main risk factor in glaucoma. Just like to acknowledge my co-authors on this research, especially my colleague Dr Henry Marshall and my supervisor Professor Jamie Craig, for both their hard work and support while undertaking this research.
Thanks, Ella. Does anyone have any questions? We encourage questions on the app, but if I'm happy to take the microphone around if anyone has any questions.
I have a question for Ella if no one from the audience does. Do you think this is related to higher BMI being associated with raised intracranial pressure and alterations in the translaminar pressure gradient?
I mean, I suppose that's one theory. I think there's a few different thoughts to why the higher BMI might have correlations with a higher IOP, and that being one. Another being an overestimation of Goldman applanation tonometry when measuring the IOP of overweight individuals and having improper like sitting at the slit lamp, and then also finally having an increased adipose tissue in the orbital area, potentially increasing the IOP.
Thank you. Anyone else? Lovely. Thank you so much. So we'll move on to our next speaker. I'd like to introduce Dr Maryam Eghtedari, who's going to talk to us about multifocal VEPs.
Thank you. Thanks for the opportunity to present this interesting study. We have looked at the automation of the analysis of multifocal visual evoked potentials using artificial intelligence. To begin with, I'd like to put this study into a clinical context. The subjects of our study are patients with multiple sclerosis or MS and optic neuritis. And MS is a neuroinflammatory disease characterized by demyelination. And the remyelinating therapies are emerging promising therapies that are at the moment in clinical trials in need of good biomarkers to assess the efficacy of the disease. MS affects the axonal conduction in neurons, and multifocal visual evoked potentials are a good modality to assess axonal conduction. MFVPs are occipital scalp electrode recordings of brain signals in response to visual stimuli. The issue is that MFVPs produce a large number of data, and we need an efficient way to be able to analyze them. For example, we have in this eye, about 56 segments that have been produced as a result of MFVP analysis. And experts will go over these segments and divide them to a few categories, including if there's a noisy signal, whether there is an upslope signal or whether there's a downslope signal. And the direction of the peak is important because we need to measure the latency of the signals, and the axonal conduction from that will be derived. So the aim of this project was to find a way to automate this process, because when an expert does that, it takes between 20 to 30 minutes to go through these traces. Our methods included looking at data from 10 patients that yielded 2,240 traces. These patients had the diagnosis of relapsing remitting MS per McDonald's criteria, and they had at least a 6-month history of optic neuritis with a visual acuity of greater than 6, of at least 6 out of 12. And these traces was first analyzed by an expert, and this was done twice, once at day 1 and then another time a week after that. And that's how we had an inter-rater operability. And these traces were then divided to training data set, 70%, and a testing data set. We used 2 softwares called ResNet50 and VGG16 as our AIs. They're common AIs that are used for image-based analysis and pattern recognition in medical research. And we asked our AIs to give us outputs to see whether they're noisy traces or upward trace or upsloped signals or downslope signals. Now, here's our results, and I'd like to draw attention to this first box over here, and also here for this table representing the performance data for ResNet50, and this table here, performance data for VGG16. So in terms of the ResNet50 data, it shows that in 98.3% of the cases, this AI was actually competent in picking up no signal or noisy traces. And in terms of VGG16, that number was 99.4%. In terms of picking up the actual signals, both softwares were quite sensitive and quite comparable to the human expert. So the upload signals were picked up 80% of the time, and the downward ones 92%, 93% of the time were with the ResNet50, and the numbers were a 90% in both cases with VGG16, so both quite sensitive. So in conclusion, our models efficiently analyze MFVPs with a false positive rate of less than 2%. And very importantly, AIs can do this analysis in about 1 minute, whilst it takes about 20 to 30 minutes to analyze data for each eye for an expert human. And this is a promising tool to act as a biomarker of clinical trials for remyelinating agents for MS. Thanks very much.
Any questions? I have one question. So what were the differences between the 2 models, and would you see in the future one model being used versus the other?
Thank you. We prefer and recommend VGG16 over ResNet50. The way we've optimized the models were to have a very false positive rate as well as to keep up the sensitivity. And I think VGG16 proved a quite small, less than 1% false positive rate, because we don't want the noisy traces to be included as true signals and then analyzed for clinical data measurements. And at the same time, whilst having a very low false positive rate, VGG16 proved a quite high sensitivity as well. So that would be what we recommend moving forwards in practice. Thank you.
Thank you very much. Oh, there's one question at the back before you go, Maryam.
Yeah.
James?
single patient and then draw conclusions as to the application of AI across a broader data set. I mean, there was another presentation in this morning's session looking at retinal ischemia, and they had a relatively small number of patients, but they looked pixel by pixel, so they had tens of thousands of data, or hundreds of thousands of data points for each patient. I just wonder about the validity of that in a mathematical sense or otherwise. Is it a valid approach? Because normally when you look at AI data sets, you have tens of thousands of individual patients, and it's, again, I guess it's a more global thing that you're looking at. Can you just comment on that validity of this approach to developing AI?
Thanks, James. It's a great point, and essentially it's a conversation about how general this approach can be. The fact is that the AI can become more reliable when more patients are included, and certainly in term and to increase its validity with more number of patients. And I take the point about having lots of data points from the same patients. Would that, I suppose the question is, would that increase its validity, or do we need more patients and more data sets to factor for the differences? And I suppose for this study, the effort has been to troubleshoot this via, for example, the testing data set that we use were completely different patients compared to their training data sets, as well as the AIs that we used, the machines that gathered the data for the AIs were the same, but the centers were different. So we did take into account how could we make things more general. But in summary, to answer your question, we certainly can increase the validity with having more patients analyzed, and I think that would make the AIs more reliable. This would be a good first step, though, to prove that we can have something to soon replace humans in a I suppose, efficient and valid way. Certainly, we need data from more patients and more centers to give enough information to our machines. Thanks.
Thank you very much. Thank you.
Thank you.
So I'd now like to introduce Dr Nigel Khoo, who's going to talk to us about alleviating headaches, maybe for the patients and for us.
Thank you. Hi everyone, my name's Nigel. I'm one of the residents at Sydney Eye Hospital, and today I'm here to talk about my research project titled The Surgical Correction of Refractive Error, Alleviate Headache in Patients with Keratoconus, a retrospective analysis. Now, just a bit of background. Refractive error has long been thought to be a cause for headache, and this is widely believed by the ophthalmic community. However, to this day, there is poor evidence confirming this link. Historically, studies involving this topic included patients with headache of different pathogenesis, and they were all examined in the same cohort, so this makes any direct conclusion between refractive error and headache difficult. However, this is a very important topic because ophthalmologists remain the third most consulted for headaches of recent onset. Now, so a bit on keratoconus. We all know it causes high myopia and astigmatism. This introduces an irregular cornea, results in high myopia. But the good news is that through an excimer laser by means of photorefractive keratectomy and collagen cross-linking, this results in a flattened cornea and correction of refractive error. So we had quite a number of patients come back to our clinic and said, "Doctor, after my operation, after correction of with surgery, my headaches are gone completely. I've stopped taking all my migraine meds altogether." What did we do? We investigated if the surgical correction of refractive error through PRK and CXL alleviated headache in patients with keratoconus in an appropriately classified patient population. So we only included patients who met criteria for headache as outlined by the ICHG-3 by the International Headache Society. The study design was by a retrospective questionnaire, and 40 out of 60 patients with keratoconus met inclusion criteria. Patients were asked about the quality of their headaches and the nature of their headaches as seen here in this questionnaire. and also the impact of the headache on your quality of life by means of the HIT6 questionnaire, both preoperatively and postoperatively. And once again, most importantly, only patients who suffered from headache associated with refractive error, migraine, and tension type headache were included in the study. Patients with headache of different pathogenesis were excluded. Now, results-wise, very interesting. So before the operation, 24 out of patients had headache preoperatively. And after PRK and collagen cross-linking, only 9 patients had headache postoperatively. And this finding was statistically significant. We subdivided the overall headache group into migraine, headache associated with refractive error, and tension type headache. And this trend was seen across all headache subgroups. So overall, there was a reduction in patients who had headache postoperatively. The average number of days of headache per week was about 4 before the operation. And after the operation, this reduced to about half a day. And as seen to the right here on this bar chart, this basically shows a reduction in the duration of headache from about 2 hours to about half an hour. And this was statistically significant too. A bit more insight on analgesia consumption. It's interesting to note that 61% of patients who consume analgesia before the operation stopped consuming analgesia altogether after PRK and collagen cross-linking. This trend was also seen in patients who took simple painkillers, triptans, and opioids. Now, it's really interesting to note that patients suffering from headache generally had a higher spherical and cylindrical power, as evidenced on this bar chart here, both preoperatively and postoperatively. This trend was seen. So the higher the spherical or cylindrical power, the more likely the patient is to suffer from headache. In terms of quality of life, we assess this through the HIT6 questionnaires, which is used by neurologists across the globe. And overall, the mean HIT6 score went down. So the lower the score, the higher the quality of life. And this was seen in our group. Discussion-wise, so correction of refractive error by means of PRK and CXL resulted in a significant improvement in headache. 60% of patients with keratoconus experience headache preoperatively, and this suggests that headache is a common occurrence amongst patients with keratoconus. Also, a large proportion of patients, 61%, stopped consuming analgesia altogether, and this suggests that a correction of refractive error can play a role in alleviating headache, especially in patients with keratoconus. In conclusion, surgical correction of refractive error in patients with keratoconus can result in a significant improvement of headache with significant socioeconomic improvements. For example, fewer sick days at work, increased workplace productivity. This highlights the importance of an appropriate refraction and referral of myopic patients with headaches of recent onset to an ophthalmologist for exclusion of keratoconus as a potential cause. Just like to acknowledge my supervisors, Professor Claire Fraser, Dr. Bronwyn Jenkins, Ms. Angelique Antonio, Dr. Greg Maloney. This would not have been possible without your support and help, and I'm very grateful. And also thank you to the organizers of Radiological 2022 for giving me the opportunity to speak here today. Thank you. Any questions?
We've got one question at the back.
Hi, thanks for the talk. It's more about the technique. Was it cross-linking and PRK performed at the same city, combined at the same time?
Yes, correct.
And was it predominantly on myopic or refractive errors rather than like we had mixed astigmatism? Did you treat that group of patients particularly?
Yeah, so only patients with keratoconus, with high myopia and astigmatism were included.
Did you have a range of refractive error that you wouldn't treat in that group?
No. In this subgroup, only patients with high myopia was treated. We didn't explore patients with mild or moderate myopia, but this opens avenues for further researching.
Were you actually fully correcting the refractive error, or were you just reducing the magnitude?
Reducing the magnitude. It wasn't in most patients. It wouldn't be to ametropia, but it would be significantly reducing the magnitude of high myopia.
One last question: did you use mitomycin at the same time as the
I don't think so. I'll need to check with my supervisor, but I don't think so. I need to get back to you on that. Yeah. Yeah, I'll need to get back to you on that. Yeah.
I think there's one question at the back.
Hi. Sure. Thank you.
I think we better move on. If you have any other questions, please nab Nigel at the afternoon tea after the session. Thank you so much. Our next speaker is Dr Tabitha Scott, Radiological Findings of Paediatric Orbital Cellulitis. Thanks, Tabitha.
Thanks. Hi, my name is Tabitha Scott. I currently work at the Princess Alexandra Hospital here in Brisbane, and I'd like to thank you for coming along to listen to our presentation on radiological findings in pediatric orbital cellulitis. So pediatric orbital cellulitis is a rare but sight-threatening condition with a reported incidence of 0.3 to 2 admissions per month at tertiary pediatric facilities. Radiological findings can provide insight and clinical direction into differentiating between pre- and post-septal cellulitis and guide prompt and appropriate treatment. The aims of this study were firstly to determine the incidence of post-septal cellulitis at our institution, and secondly, to assess the radiological patterns of more severe disease. A bit on background and the risk of radiation exposure. It's something we need to keep in mind with our pediatric population, and a discussion we might need to have with weighing up the risks and benefits of imaging. So as you can see on the table on the left-hand side there, a head CT scan delivers an effective radiation dose of 1.5 to 2.5 millisieverts, which is the average accumulated background radiation dose to an individual over a year. This falls within the mid-range of exposure, with X-rays being on the lower end of the spectrum and an abdominal CT providing over double an effective dose of this. From an Australian pediatric study, the estimated risk of one extra cancer case per 1,800 CT scans were performed, while the Australian Radiation Protection and Nuclear Safety Agency estimates the lifetime risk of cancer as 1 per 1,000 pediatric scans. In regards to methodology, this was a single-center retrospective review of all pediatric patients admitted with pre- and post-septal cellulitis between the 1st of January 2007 and the 31st of December 2016. The data collated included patient demographics, clinical signs, whether radiological imaging was performed, the type of imaging, and the findings. If we look at results now, there were 237 patients admitted during this time period. 206 patients had pre-septal cellulitis and 31 patients had post-septal cellulitis. Of this total number, 50 patients underwent radiological imaging with a median age of 6, and 78% of them were male. Within that group, 42 underwent CT scan, 1 underwent MRI scan, and 7 underwent both CT and MRI scan. If we look at the group who underwent CT scanning in regards to Chandler grading, 47% were Chandler grade 1, 27% Chandler grade 2, 22% grade 3, and 4% grade 4. No patients were grade 5 or sinus venous thrombosis. Overall, the CT yield for post-septal involvement was nearly 61%, while involvement of subperiosteal or orbital abscess was 31%. If we look at those who underwent MRI scanning, the severity of disease was quite significantly worse to begin with. So 50% of patients were Chandler grade 2 and 25% were Chandler grade 4, with grades 1 and 3 making up approximately 12%. And again, there was no patients who were Chandler grade 5. Now, the indication for patients who underwent MRI was predominantly for those patients who had orbital abscesses and were moving forward to planning operative intervention. 75% of those 8 patients who underwent MRI scan did progress to surgical intervention, which was predominantly performed by our ear, nose, and throat colleagues with a FES procedure.
If we look closer now at the radiological findings within the CT scans, the most common finding was that of sinusitis, and this occurred in 88% of patients. Subperiosteal abscess was the second most common finding in 22%, followed by lamina papricia dehiscence in 16% and orbital displacement in 14%. Those who had orbital displacement, the subperiosteal abscesses were most commonly located medially, and this was in 73%, followed by inferiorly in 18% and 9% superiorly. Looking at those who had sinusitis, the most common locations were the ethmoidal or maxillary sinuses in 29% each respectively. This was followed by frontal sinusitis in 18%, sphenoidal sinusitis in 11%, and pansinusitis in 13%. Now, one interesting point was that the largest subperiosteal abscess was located superiorly, and it actually measured 26 by 18 by 16 millimeters. And this patient was actually ended up having meningitis and was quite unwell. It's just an interesting finding. So in conclusion, the incidence at our institution of post-septal cellulitis was 13.1%, which equates to 0.27 cases per month, which is on the lower end of the spectrum of what's in the data. CT scanning was the imaging modality of choice, but overall, there were a low number of scans performed in children. So this data could be used to help create guidance for pediatric radiological imaging for orbital cellulitis and guide us to look in these higher yield areas. So thank you very much.
I have a question.
Yeah.
So in the children who received a CT and an MRI, do you think the second imaging modality was required? Did it change management? Or could decisions have been made based on just the first scan?
Yeah, thank you. So all the children, I guess, first of all, just the decision to scan was up to the treating team, which varied quite a bit between being pediatrics, ophthalmology, ENT, max. And those who all progressed to MRI had a CT scan first, but were either not improving on empiric antibiotic therapy or had worsened, and that's what led them to perform an MRI scan instead.
James, you have a question?
Two questions. The first one is, at your unit, do you have a protocol for the management of preseptal and orbital cellulitis?
So this study was, so this study was done at the John Hunter Hospital. There was no formal protocol at the time, but we're hoping to help develop one based on this. Typically, the most common empiric antibiotic therapy used was flucloxacillin and ceftriaxone, but the sort of decision to image was based on the discretion of the clinician and treating team. And the most common factors we found was failure to improve within 48 hours of treatment, and then fever, leukocytosis, reduced visual acuity, reduced color vision were key themes that we picked up in the data. Yeah.
The other is, did you make any attempt to measure the volume of the subperiosteal abscesses? There's some evidence in the literature that certain volumes are more likely to require drainage.
Unfortunately, we didn't do that, but that would be a good thing to go look back on.
There's one paper in the literature suggests 1.25 millilitres is the cutoff between managing conservatively and then surgical intervention. So that would be worth looking at. You may not have enough data.
Yeah. Thank you.
Thank you very much. I'd like to introduce our next speaker, Dr Amy Wang, who's going to talk to us about a snapshot of preferred treatment patterns for retinopathy of prematurity.
Hi everyone, my name is Amy Wang and I currently work at the Queensland Children's Hospital in Brisbane. Thank you for this opportunity to present our work, a 10-year snapshot of preferred treatment patterns of ROP. Now, ROP is the leading cause of blindness in children worldwide, and traditionally treatment has been with laser, but treatment with anti-VEGF has been gaining popularity since the BETA-ROP and Rainbow studies. In spite of these shifts, there is still a lack of consensus on treatment patterns amongst clinicians. Treatment is predominantly based on ET-ROP guidelines as defined by type 1 ROP, which is any stage with plus disease, and anything above stage 3 without plus disease. Our study is aimed at assessing treatment patterns of ROP internationally. Now, between March and May of this year, a retrospective survey was distributed to ophthalmologists performing ROP screening and treatment internationally via a pediatric ophthalmologist email listserv. A total of 54 responses were received from clinicians in 11 different countries. Treatment patterns of ROP were over a 10-year time frame between 2012 to 2022 was assessed, as well as preferred modality for first-line treatment. Those that failed initial treatment with anti-VEGF or laser requiring repeat treatment and follow-up in the active screening phase, as well as post-discharge. Now, our responses found a total of 6,919 babies that were treated in the 10-year time period between 2012 to 2022. Out of those treated, 56% were with anti-VEGF, whereas a lesser amount, 43% of babies, were treated with laser. Now, our results for first-line treatment options is depicted in this graph below, showing percentage of treating ophthalmologists in the y-axis, and the x-axis is represented by different groups of ROP requiring treatment. Anti-VEGF, as represented by the blue vertical column, appears to be the preferred treatment modality for posterior disease, encompassing aggressive ROP and type 1 ROP in zone 1 and posterior zone 2. On the other hand, laser, as represented by the green column, appears to be the preferred treatment modality in more peripheral disease, such as type 1 disease and anterior zone 2 and zone 3. A minority of clinicians reported using both anti-VEGF and laser as first-line therapy. An even smaller amount of clinicians comparatively used other treatment modalities, such as cryotherapy. For babies not responding to initial treatment, repeat treatments may be required, and overall, in this graph, laser appears to be the most used treatment modality. Now, follow-up post-anti-VEGF treatment, as depicted in weeks post-menstrual age, mostly is between 55 to 60 weeks, with the majority, 38%, preferring more than 60 weeks. A small number of ophthalmologists reported follow-up less than 55 weeks. There is no obvious consensus in the follow-up post-discharge from active screening, with the majority of ophthalmologists reporting follow-up between 3 to 6 months. There is a small minority of ophthalmologists reporting follow-up more than 6 or 12 months, and about 20% reported varied follow-up anywhere between 4 to 18 months. Now, according to this survey, anti-VEGF is the preferred treatment modality for posterior disease, and laser is the preferred treatment for more peripheral zones and repeat treatments. In terms of primary treatment, slightly more than half prefer to use anti-VEGF as compared with laser. An interval follow-up post-anti-VEGF treatment is quite variable. There appeared to be no universal agreement for long-term follow-up. Thank you.
Any questions? I have a question. Did you see a difference in practice pattern between different countries or regions?
Not too much. I mean, between the 11 countries, we sort of all saw either more sort of predominant use of bevacizumab versus ranibizumab, or perhaps a majority of, the more North American or Australian countries using the same sort of follow-up patterns, and then the more Asian Pacific countries using different follow-up patterns. Those were kind of the main things that we found.
I think James Smith had a question.
Yeah, I suppose one implication of your study seems to suggest that there's a huge increase in of the cohort of people that treat. There's a huge increase in the most severe disease occurring most posteriorly. That's what I gather from your data, because most people are treating with an anti-VEGF agent, which we only use in the most severe disease. Is that?
Yes, I guess that's suppose a little bit confounding in the sense that we normally would treat posterior disease with anti-VEGF anyway, and that's what the anecdotal sort of evidence from our survey showed. So there's sort of overlap between that result. So I'm not sure if we can conclude that there is a huge increase. We can just say that these number of clinicians that responded to the survey are using anti-VEGF for posterior disease.
James?
I'd have a comment on that, James, that I think there may be
Thank you so much. Thank you. Oh, one quick comment from Sean.
I was supposed to be quiet because I want to also study. I think the reason we did the study, I kind of feel we all feel trigger happy use alleviate. I said, let's do a map of data actually to see is it true. I personally have not used laser as a primary therapy for the last 4 or 5 years. So that tells me actually when we do these things, actually result actually we know. So it just confirms we are actually very subjective. I think the class disease is the one
Thank you so much. Great discussion. So we'll move on to our next speaker, and I'd like to introduce Dr. Elise Perrin, who's going to talk to us about some ocular motility abnormalities.
So hi everyone, I'm Elise. I'm one of the ophthalmology PHOs working at the Princess Alexandra Hospital. Today I'll be presenting our paper examining the prevalence and outcomes of ocular motility abnormalities in children with Chiari malformations. So why did we do this study? So rates of identification of Chiari malformation have risen with increased use of MRIs, and while the majority of patients are asymptomatic, those who aren't may present with headaches, neck pain, cerebellar dysfunction, limb sensory and motor disturbance, and oropharyngeal dysfunction. And the indications for surgical intervention in these patients are reasonably well established. But patients can also present with ophthalmic manifestations, in particular esotropia, and in these cases the management is not so clear. Posterior fossa decompression as the first surgical intervention is invasive, whereas strabismus surgery doesn't address the underlying pathophysiological process, which raises the question of whether strabismus will reoccur. It has been suggested that posterior fossa decompression then strabismus surgery may be the best approach. However, there's currently very limited data published on ophthalmic outcomes following posterior fossa decompression to date, and results are variable. So we therefore decided to review the incidence of strabismus and other ocular findings in patients undergoing posterior fossa decompression for Chiari malformation, as well as assess their outcomes. So what did we do? So this was a retrospective chart review of all patients who underwent posterior fossa decompression for Chiari malformation at the Queensland Children's Hospital over a 15-year period. We included any patient under the age of 18 at the time of their posterior fossa decompression, but we did limit our review to patients with Chiari 1 malformation only. 104 records were identified, of which 29 patients had undergone documented ophthalmic review and were included. A minimum follow-up period of 6 months was set, although most patients were followed for several years. Indications for posterior fossa decompression included failing conservative management with severe or progressive symptoms or syringomyelia. Where available, we recorded the type of strabismus, the angles for distance and near pre and post-operatively. We looked at patient demographics, vision, cycloplegia refraction, and any additional interventions, including strabismus surgery and the presence or absence of full refractive correction. We recorded rates of papilledema, diplopia, and nystagmus. So of the 29 patients that had documented ophthalmic reviews, 17 had some form of ophthalmic abnormality. The most common abnormality was strabismus, which was present in 12 patients. 9 of these patients had esotropia. 3 patients were noted to have nystagmus, and this was horizontal for all the patients for whom it was specified. 3 patients had optic disc swelling, 1 of whom had concurrent idiopathic intracranial hypertension, and another of whom had concurrent obesity secondary to Albright's renal osteodystrophy. 2 patients had optic disc pallor, and one of this occurred in the context of severe vitamin A deficiency. So looking a little bit more detail now at our original question, what impact did posterior fossa decompression have on strabismus? So of the patients with esotropia, 6 had sufficient pre- and post-operative data recorded to infer the impact of posterior fossa decompression on their ocular alignment. 3 patients underwent posterior fossa decompression in isolation. 1 patient experienced complete resolution of their esotropia with posterior fossa decompression as the only intervention. In this patient, orthotropia was present at the 6-week post-operative review and was maintained throughout the several-year follow-up period. The second patient had significant improvement from 30 prism diopters to 10 prism diopters without further intervention. And a third had no change in their strabismus, but they did have very poor vision in one eye, secondary to optic nerve hyperplasia. 2 patients underwent posterior fossa decompression followed by strabismus surgery. The first of these had only a microesotropia at 6-month follow-up. The second patient actually initially experienced worsening of their esotropia after posterior fossa decompression, then subsequently went on to have strabismus surgery. So they went from 20 prism diopter alternating esotropia prior to posterior fossa decompression to a 40 prism diopter alternating esotropia. And 19 months post strabismus surgery, this had reduced to a 14 prism diopter left esotropia for distance. One patient had concurrent idiopathic intracranial hypertension with right esotropia and bilateral cranial nerve 6 palsies. This patient underwent posterior fossa decompression, but also a ventricular peritoneal shunt insertion. And while they did have complete resolution of their strabismus, it's not really possible to say whether that was from the posterior fossa decompression given the concurrent intervention. So in conclusion, in our population, ophthalmic manifestations were common in patients with Chiari 1 malformation undergoing posterior fossa decompression. They were present in 58% of patients reviewed, although our sample would of course be biased by the fact that patients would be more likely to undergo ophthalmic review if there was concern for eye symptoms. As in the limited published data available to date, we found the impact of posterior fossa decompression on strabismus to be variable. However, overall, there was a trend towards improvement in ocular alignment post-posterior fossa decompression. Certainly, more research and bigger sample sizes are needed to obtain sufficient statistical power, but our results would appear to support the notion that strabismus surgery should be done after posterior fossa decompression if required. Thanks.
Any questions? Yeah, James. James and James.
Yeah. Correct. Yeah. And we did sort of, although we were going through the Children's Hospital, we did contact some private practices as well to see if the patients had attended there for eye reviews. Obviously, that's not a complete, thorough assessment. We couldn't identify any extra ones there either.
The same occurs in adults as well.
Did any of your patients present with esotropia as the first manifestation of their Chiari malformation?
Yes, so one patient that was included did present with esotropia as the first manifestation of their Chiari malformation, so it was identified on workup for their esotropia, yes.
And further to that, I presume this is not the case, but did that patient have exercise-induced esotropia?
I would have to check and get back to you on that.
Because that's a rare initial manifestation of Chiari malformation is to have esotropia that's induced by getting hot and sweaty. I've seen 2 cases of that as the initial presentation of Chiari malformation, and they have an intermittent esotropia on exercise.
Can I answer your question? The answer is no, because I only saw the child on Monday. And they actually become my prior patient, but mom is a physician, so I give you a report.
Thank you.
Lovely. Thank you very much. Our next speaker is Dr. Sophia Zagora, who's going to talk to us about paediatric uveitis.
Thank you very much. I'll be talking about the improving paediatric uveitis visual outcomes and quality of life. So we're talking about a changing paradigm in the treatment of paediatric uveitis, and it's one of the orphan diseases. And what happens is they present at later stages of disease, which often leads to a lifetime of visual loss. And we've also been found that they have increased rates of anxiety and depression. We all know that the mainstay of uveitis for a long time has been steroids. And in children, this leads to a higher rate of ocular hypertension, glaucoma, and cataract. And glaucoma is one of the major causes of vision loss. This incidence of secondary glaucoma in children with uveitis is between 10.3 to 42%, and incidence of blindness is 7%. And that's why it's led to this paradigm change where we're now using steroid-sparing agents a lot earlier, and we're also moving to biologic therapy earlier as well. And that use of these agents has meant that we've now had to use a multidisciplinary clinic, which has been set by the EULAR guidelines as being the gold standard of care. In New South Wales, we've been doing ours since 2016, and there's a number of these clinics around Australia optimising the paediatric care. So what am I looking at? I'm looking at a number of things, trying to investigate the visual outcomes of these paediatric uveitis in relation to this diagnosis and treatment, and now use of steroid-sparing agents and biologics, and then investigating the rates and timing of cataract and glaucoma surgery, And then after this, looking to explore whether these changes are actually improving our patient and carers' quality of life. So starting with a retrospective review of the paediatric data from the Children's Hospital at Westmead, Sydney Eye Hospital and Save Sight Institute from 2005 to 2021, and then prospectively moving to patients and carers completing validated health-related questionnaires and quality of life questionnaires, and then correlating that with their clinical data. In the interest of this talk, I'll focus on the retrospective data. So inclusion criteria is less than 18 years of diagnosis, any form of diagnosis based on the SUN criteria, follow-up of at least 3 months, and the paediatric glaucoma guidelines for ocular hypertension and glaucoma, ocular morbidities and their treatment. And we found 145 children, so 235 eyes diagnosed with paediatric uveitis, the majority of bilateral, 79 female, and the most common diagnosis is that in association with JIA uveitis, and then secondary idiopathic uveitis. And in most of our clinics, as we see, the majority of this is anterior uveitis. And we found 67 patients treated on methotrexate and mycophenolate, 42 patients on adalimumab, 4 patients changed in infliximab, 5 patients on tocilizumab, and 2 patients now on JAK inhibitors. And some have been progressed through the different treatments. Interestingly, and this is a very big shift for parents to get around, is that 20% are only unilateral and have no documented active arthritis, but we're putting them on these biologics and systemic treatment for their uveitis. And the mean duration of inflammation prior to commencement of biologic over the whole study period was 22 months, but since looking back from 2016 onwards, that has now reduced markedly to 12.2 months. Baseline age commencement of biologic was 9.12 years. And then this just highlights that once we put them on the biologic, the vision improves within the first 6 weeks and then is maintained over the 12 months. In terms of ocular hypertension, glaucoma and cataracts, over 60% of eyes diagnosed with uveitis at some point developed raised IOP, and close to 74%, this was presumed to be steroid-induced. 49 out of the 232 eyes had glaucoma surgery, with some eyes having multiple surgeries, including both glaucoma drainage devices and trabeculectomy surgery. We had 56 out of the 232 eyes having cataract surgery, and we are noting a decline in both of these from 2017 onwards. And it's been documented well in the literature that there is definitely a dose-dependent rate of increase in ocular hypertension and glaucoma and surgical procedures based on the number of drops per day, and we also found this, and obviously more in our anterior uveitis patients. So in terms of conclusions, managing paediatric uveitis is very complex. The most important thing is to control the intraocular inflammation. We're rapidly tapering steroids to try and avoid ocular hypertension, glaucoma and cataract. And with stepwise treatment, we're moving directly to disease-modifying agents and biologic therapy. And we are starting to see a decline in the glaucoma and cataract surgery rates over the last few years. Obviously, it's very short, but we'll continue to follow this. And patients and carers are starting to report improved quality of life, which we're now looking at. And just a plug that we were invited to speak at the rheumatology parliamentary inquiry earlier this year on our treatment in paediatric uveitis as Australia-wide group.
Thanks, Sophia. Any questions? James?
Sorry. I'm interested in this with the number that have gone from methotrexate onto the biologics. You had 67 on methotrexate. Were those 67, 40 of them failed and went on to biologics, or were 67 improved with methotrexate alone?
It's actually very hard to document because a lot of them then we keep them on methotrexate.
Yes, that's the basis of my question.
Yeah,
so in actual fact, did only 1/3 of the patients who were started on methotrexate get adequate control?
Yes, I'd say it's as low as that. because we're moving very quickly to biologic therapy, and then we do maintain them on methotrexate to stop their autoantibodies.
No, can I compliment you on that study, because we've done a similar one in Melbourne, and it was, can I say, Anu, a dog's breakfast?
Yes, it was
in
very
terms
messy.
of, we were anticipating seeing that reduction since the biologics, because we've been using biologics there for about 12 years. We had a lot more patients years ago in infliximab, but we did not show any sort of correlation with improved outcomes. Is that correct, Anu? It's sort of what we
yeah, numbers were very small, so I was going to talk to you afterwards about combining. But yes, the feeling was that our practice would reflect yours, but it didn't show in our study.
I think that's another reason to include quality of life data, because it's not just about, I guess, numbers. It's also about the patient's quality of life and depression and anxiety and sort of lifelong loss of vision that we're looking at as well.
One other comment about that, there's an awful lot of needle phobia anxiety and things like that. So it can work both ways in terms of the quality of life. There's a lot of children who are very distressed by their fortnightly Humira injections.
And the citrate freeze made a huge difference.
Yeah, absolutely.
Thank you very much. Our next speaker is Dr Amelia Bai, who's going to talk to us about AI and ROP.
Hi everyone, thank you for this opportunity. My name is Amelia Bai. I'm one of the ophthalmology unaccredited registrars here at the Queensland Children's Hospital, and today I'll be talking about our research multi-centre evaluation of an artificial intelligence algorithm for the diagnosis of retinopathy of prematurity. So retinopathy of prematurity is a sight-threatening vasoproliferative retinal disease, and plus disease is a severe treatment-requiring form of this, which is characterized by vascular tortuosity and dilatation seen on fundus exam. Unfortunately, the diagnosis of plus disease is extremely subjective in nature, with significant inter- and intravariability reported amongst ROP experts around the world. And so our research aims to overcome this subjectivity through the use of artificial intelligence technology. Now, artificial intelligence is a very broad term, but it encompasses any sort of technology with decision-making capabilities. And deep learning is an advanced form of this AI, which can self-learn through image features from training sets. So ROP AI is our deep learning algorithm, which is a fully automated algorithm designed to diagnose plus disease from retinal images. And this initial algorithm was created from 6,974 posterior pole images captured from a single New Zealand cohort. And these images were initially graded by a single clinician for the detection of plus disease. So our aim of this study was to externally validate this ROP AI algorithm against retinal images collected from across Australia and compare the diagnostic performance with 5 ROP experts. And our preliminary results from the initial creation of the AI algorithm against 90 posterior pole images showed 97% sensitivity, 78.9% specificity, and 97.8% negative predictive value in the detection of plus disease. So our question here today really is, can ROP AI detect plus disease with high performance following large-scale external validation on retinal images without a strict inclusion or exclusion criteria? So we were able to collect over 8,000 unprocessed retinal images retrospectively from 5 major tertiary centres around Australia. As you can see here, we had 10% of them were plus disease, 17% were pre-plus disease, and 73% were normal images. The corresponding clinical diagnosis was recorded from one of 5 ROP experts across Australia. And these retinal images were uploaded to the ROP AI for diagnostic evaluation. So you can see here that this is our AI platform, and an image is imported into the algorithm, and an output from 0 to 1 is recorded. So 0 being normal and 1 being plus disease. So you can see in the first image, it's been diagnosed as a normal image. And the second image here is graded as 1, meaning plus disease. And down the bottom, you can see a saliency map, which gives us an idea of what the AI algorithm is looking at when it diagnoses this. So these outputs are then compared to the ROP expert's diagnosis for each image, and from that we were able to determine sensitivity, specificity, and negative predictive value. Our results show that ROP AI was able to detect plus disease with high sensitivity and negative predictive value compared to ROP experts as the gold standard. So we were able to produce a 96% negative predictive value, meaning that 96% of patients with a negative test are actually free from plus disease. Additionally, ROP AI demonstrated generalizability with reproducible performance on this novel test set from images it had never seen before. And finally, ROP AI produced high performance in the diagnosis of plus disease without any image pre-processing or strict exclusion criteria. So what do these results mean? It tells us that ROP has the ability to detect plus disease despite being despite being tested against these new images from Australia and compared to 5 ROP experts. Secondly, ROP AI produced high sensitivity and negative predictive value, which are the two most important features of a screening test in order to not miss diagnosis. Thirdly, the images captured were captured during routine ROP screening, and this simulates real-world applicability of this algorithm. And finally, to the best of our knowledge, this is the first ROP deep learning algorithm to undergo large-scale external validation. And so where do we go from here? So we've already developed our AI algorithm, and this talk discusses the multi-center validation of this algorithm. And we hope to take the over 8,000 images that we've collected and retrain this algorithm to create a better performing algorithm. And finally, we hope that this may be produced into a prospective trial of ROP AI diagnosis compared to ROP experts by the bedside in real time. And finally, for the future, we hope that this may be implemented as a decision support tool for the diagnosis of plus disease. Thank you.
Thank you. We have one question there.
Just quickly, did you find any issues with the modality which the image was captured? If there were different modalities, did that lead to any issues with processing of the data?
So all of our images collected were from RetCam imaging, so we didn't run into that trouble. Yeah.
Another question in the front.
So do you think in the future you're going to use your AI for diagnosis or for triage in real life?
For screening purposes.
Did you just use one expert to make the ground truth for the AI, or did you have several ROP experts grade each image? Because I think we already heard that there might be some disagreement between ROP experts.
Yeah, so our initial algorithm was from one ROP expert as a ground truth, but that's why we did this multi-center validation and we used 5 ROP experts as the ground truth. But that being said, it was only one of the 5 that diagnosed each image.
Any other questions? Is there one in the middle?
We haven't done that analysis, but we will be looking into it. Thank you.
All right, thank you very much. Our next speaker is Dr. Alexander Bremner. He's going to talk about the validation of weight gain-based prediction models for ROP.
Thank you. My name's Alex. I'm one of the principal house officers at Royal Brisbane. Thank you for the opportunity for allowing me to present my abstract today. Its titled Validation of Retinopathy Prematurity Weight Gain-Based Models in an Australian Population. So premature infants at risk of developing ROP requires frequent retinal screening examinations to detect pre-threshold disease where treatment has been shown to reduce the incidence of unfavourable outcomes in vision and structure. The current guidelines of retinopathy prematurity screening are based on 2 risk factors, birth weight and gestational age. The current guidelines are only detecting a small proportion of infants who end up developing type 1 retinopathy prematurity. So it exposes the vast majority of these infants who are being screened to systemic effects such as the ocular cardiac reflex or the systemic side effects of the mydriatics. So to improve the detection of treatment requiring retinopathy prematurity, it's been guided by the pathophysiology studies on retinopathy prematurity. And one of the risk factors that we're looking at was insulin-like growth factor and its association with postnatal weight gain. We know that insulin-like growth factor, as shown in the picture on the left, has a role in both phases of the development of retinopathy prematurity. In phase 1 of the development of the avascular retina, and in phase 2, where there's an increase in angiogenic factors which can cause neovascularization. Studies have shown that there is a correlation between insulin-like growth factor 1 levels and postnatal weight gain. And so my study was looking at the performance of the four most commonly studied postnatal weight gain algorithms in an Australian population. This was a retrospective cohort study that included premature infants screened at the Tertiary Hospital in Brisbane. The data collected included birth weight, gestational age, demographics, postnatal weight gain, and the final ROP diagnosis. Infants would have been excluded if there was insufficient weight measurements that could be used to determine whether or not an infant would be screened by these models, and if there was any causes of artificial weight gain. The four retinopathy prematurity models, that was studied was the WinROP model, which was based off a Swedish cohort, and three North American models, which was the CHOP-ROP model, CoROP model, and GROP model. Each model was used to determine whether or not an infant would be screened for retinopathy prematurity. So our study included 594 infants screened over a 3-year period. We found that there was 10.6% would have been excluded, the vast majority because of insufficient weight measurements. We found that there was an incidence of 4.5% for type 1 retinopathy prematurity, and in this cohort, 100% of them had a gestational age less than 28 weeks, and 92% had a birth weight less than 1,000 grams, and 66% of this population was male. The sensitivities of CHOP-ROP, CoROP, and GROP were all 100% out of the 24 infants with type 1 retinopathy prematurity. In terms of the specificities, the CoROP and GROP model had a specificity of 30% approximately, and WinROP and CHOP-ROP had a specificity of 50%. In terms of the negative predictive values, CHOP-ROP, CoROP, and GROP all had, with 95% confidence intervals, 100% negative predictive values, which means that if these infants are testing negative in these models, they're unlikely that they're not going to develop type 1 retinopathy prematurity. So from our discussion point of view, we found a prevalence of 4.5% of infants developing type 1 retinopathy prematurity. We found that CHOP-ROP, CoROP, and GROP all performed well in this Australian population, which is consistent with other worldwide studies. And we found that CoROP and GROP were the most useful or most easiest to use clinically. We found WinROP had a poor sensitivity and didn't perform well in that population, which we suspect is because of overfitting of this model from a Swedish population to an Australian population. The study limits was that this is a retrospective cohort study and that there was only a 10% exclusion rate, but from our conclusion, we consider it could be safe to use these models in our ROP screening program to improve the efficiency. Thank you.
Any questions? I have one. So the weight gain, how long was that monitored over?
It depends on the infant. The models use different timeframes. So WinROP and CHOP-ROP, it's a weekly measurement, which isn't very practical clinically. And GROP is at 3 different time points. So from between the weight gain between day 10 and day 19, day 20 and day 29, and day 30 to day 39. And CoROP was just based on weight gain from birth weight to day 28.
Lovely. Thank you so much. I'd like to introduce back to the stage Amy Wang, who's obviously been a very busy girl.
Thanks very much for this opportunity to present again on our work on anti-VEGF treatment practices for retinopathy of prematurity. So these two landmark trials within the last 10 years have guided anti-VEGF treatment in ROP. The American BDROP study looked at laser versus bevacizumab 0.625 milligrams and found anti-VEGF to be efficacious for zone 1 ROP management. Now the European Rainbow study, which is a smaller study, looked at ranibizumab 0.1 milligrams compared with 0.2 milligrams versus laser, and they found treatment success with ranibizumab 0.2 milligrams. Based on these two studies, there appears to be an increased uptake of anti-VEGF use. Now, our study aims to examine anti-VEGF use as first-line therapy for ROP between 2 time periods, 2012 to 2019, prior to the Rainbow trial, and 2020 to 2022 post-Rainbow trial. We assessed this by utilizing a retrospective survey, which was sent out to pediatric ophthalmologists worldwide using an email listserv. Sound familiar? We also looked at trends in anti-VEGF use in ROP. Now, our results, as shown in this graph, depicts the percentage of ROP babies treated with anti-VEGF as first-line therapy, as measured in 20% intervals along the x-axis, and the percentage of treating ophthalmologists responding in the y-axis. The majority of ophthalmologists reported seldom use of anti-VEGF as first-line therapy between 2012 to 2015, as depicted by the less than 20% blue column. Between 2020 to 2022, however, there's an overall increase in all the groups using anti-VEGF as first-line therapy, as depicted by the orange columns. Similarly, prior to the Rainbow study, between 2012 to 2019, ophthalmologists rarely used anti-VEGF for repeat treatments, as depicted by the green columns. Whereas post-2020, there is a more widely distributed and overall increase in anti-VEGF that have, in those that have failed initial treatment. Now, the most used anti-VEGF agent is bevacizumab at 65%, followed by ranibizumab at 29%. Clinicians also reported using other agents such as aflibercept. And in terms of dosing, most ophthalmologists preferred bevacizumab at the half adult dose, 0.625 milligrams, and the dosing used in the BEATER-UP study. At a close second, ophthalmologists also preferred using bevacizumab at a quarter adult dose, or less, and between ranibizumab 0.1 and 0.2 milligrams, which is the dosing used in the Rainbow study, there's a slight preference for ranibizumab 0.2 milligrams. So even though there seems to be no consistency in the treatment dosage, the majority of clinicians opted for the half adult dose of bevacizumab at 0.625 milligrams. And overall, there seems to be an increase in anti-VEGF use as first-line therapy worldwide since 2020. Thank you.
Any questions? Yep, from there.
I guess Muvasi. I mean, our survey didn't really look at whether or not there was a change. We just assessed what the clinicians were using. So it'd be interesting to know.
Yeah, we've just switched to using Mvasi in Melbourne, and I think that's relatively common. It's just as easily available as so.
Yeah, same in Brisbane, and we also switched to Mavazin, and increasingly give me confidence it just works the same as Avastin. I don't know whether Jeff is here from West Australia. In a pediatric group, we reported a 60% increase of retreatment rate with Lucentis, so which is something I think we need to be aware of.
There's one question here.
I think that would be the next part, perhaps. Thank you.
Lovely. Thank you so much. Thank you, Amy. Our next speaker is Dr. Jovi Lim, who's going to talk to us about ocular melanoma.
Hello, good afternoon. My name is Jovi. I'm a clinical research fellow at University of Auckland, and I'm also doing my PhD on ocular melanoma. Today, I'll be sharing the outcomes of our study on plaque brachytherapy treatment for uveal melanoma in New Zealand. So brachy means short or short distance in Greek, and brachytherapy refers to treatment using a sealed radiation source next to the tumor. Brachytherapy has been used for treatment in many cancers, including cervical, prostate, and breast cancer since the 1900s. For choroidal melanoma, the treatment is done using a radioisotope containing either iodine or ruthenium. Plaque brachytherapy became a mainstay in treatment after this landmark study. This was a large multi-center randomized control trial over 1,300 patients, which found no significant difference in mortality between patients that were treated with enucleation or brachytherapy. Between 1995 and 2003, the iodine radioisotope was used in New Zealand, and this was done in Christchurch Hospital, and great visual outcomes from this cohort of patients was found. Since 2004, the iodine radioisotope was replaced with ruthenium isotope, and the treatment was done in Auckland, results of which has not previously been reported. So this brings us to our study, and we aim to evaluate the clinical presentation and outcomes with a focus on mortality of uveal melanoma treated with ruthenium plaques. This was a retrospective study done in a single center providing treatment to nationwide patients between 2004 and 2020. Information was obtained on demographics, presenting symptoms, tumor size that was subsequently reclassified into the AJCC tumor classification, radiation dose obtained from the medical physicist, and mortality and cause of death obtained from the Ministry of Health. In total, there were 196 patients treated over the course of the 17-year study period. The mean age at diagnosis was 62. Most of the patients were of European ethnicity with a slight female predilection. So the tumors were classified to T1 to T4, T1 being the small melanomas and T4 being the larger melanomas. Over 80% of the cases were T1 to T2 categories. Majority of our tumors treated were from the ciliary body or choroid, and most of them were pigmented. Almost half of the patients were asymptomatic at the time of diagnosis, and of those that were symptomatic, photopsia and blurred vision was the most common presentation. The median time to treatment was just over 2 weeks, and the mean dose of radiation to the apex of the tumor was 150 grays. Mortality was found in 28% of our patients, with 11% of patients dying from metastasis, and the primary location of spread was to the liver. On survival analysis, the 5-year survival from all-cause mortality was 84%, and the 5-year survival from metastatic disease was 91%, and there was a significant difference between all the tumor categories. Note here that T1 tumors had low deaths from metastasis. In the interest of time, I will focus on 3 main points from our study. So first, majority of our cases were small to medium-sized melanomas, and patients were often asymptomatic at presentation. These tumors were often detected incidentally by optometrists or ophthalmologists during routine eye exam, and they may also reflect the increased availability and use of fundus imaging modalities. Next, the time to treatment in our ocular oncology center is approximately 2 weeks, which reflects prompt service provision. Occasionally, there might be a delay in treatment as patients wanted some extra time to consider their treatment options. And lastly, we found a low disease-specific mortality in our cohort when compared to previous studies. And as we noted earlier, we did see low deaths from metastasis in T1 tumors, and they may represent treatment of high-risk nevi with suspicious features, but actually had low malignant potential. So, in conclusion, this is the first New Zealand study analyzing outcomes of ruthenium plaque treatment for uveal melanoma. Majority of our tumors treated with brachytherapy was small to medium size, and they were asymptomatic at the time of presentation. And lastly, in our cohort, we found low 5-year disease-specific mortality. I want to take this opportunity to thank my supervisors, advisor, as well as RANSCO for the opportunity to present today. Thank you.
Any questions? So how does your data compare with, do you know how the results compare to previous use of the iodine plaque?
So in the COM study, their mortality rates was about 10%, so it's similar. Yeah. Yes. Do you mean visual outcomes?
Not necessarily visual outcomes, but I guess sort of issues further down the track, like scleral necrosis or post-brachytherapy retinopathy.
Yeah. So the our Christchurch group did that. Their study looked at clinical and visual outcomes, and right now we're collecting data on the same parameters. But because a lot of our patients are treated in our center, but they have subsequent follow-up in different centers, so a bit more time is required to collect all the data from different ophthalmologists that they follow up with. Thank you.
Thank you very much. Our final speaker for the session is Dr. Rahul Chakrabarti, who's going to talk about optic nerve sheath fenestration.
Hi everyone, I'm Rahul. I'm from Melbourne. Work at the IND at the Alfred. Just like to acknowledge their traditional owners. So today I'll be presenting on a 20-year retrospective review of the optic nerve sheath fenestrations performed in Victoria. It's a multi-centre collaborative effort across the Royal Melbourne, the IND Hospital, Alfred, and also Monash. And I'd particularly like to acknowledge our oculoplastic colleagues, Tom Hardy, Alan McNabb, Charles Sue, many of whom have the three of them have performed majority, if not all of these cases. And also acknowledging our registrars, Matt Wilson and Shadi, who couldn't be here today, but they've done a lot of the groundwork on this. So as you know, optic nerve sheath fenestration performed in the appropriate setting is a recognised treatment for vision-threatening idiopathic intracranial hypertension and also cerebral venous sinus thrombosis. However, little is known about the long-term outcomes, and particularly in the setting of other disease processes. And this is why we incorporated our sort of tertiary level general hospitals as well to extract some of the cases from there. And so this is a 20-year retrospective analysis aimed to elucidate the natural history and the outcomes following optic nerve sheath fenestration over various time intervals. So data was collected from July 2000 to December 2021 retrospectively. We've compiled together patient demographics as well as visual outcomes, visual acuity, static perimetry, which was 24-2 visual field, RNFL grading, both subjectively as well as objectively on OCT, and looking at short-term complications as well. And it's largely descriptive studies. So in this study, 116 eyes from 70 patients, which is actually the fourth largest series in the world published to date. 46 patients bilateral and 24 cases unilateral. And you see in the table there, the breakdown, majority of the cases are for patients with idiopathic intracranial hypertension, cerebral venous sinus thrombosis, a small number, and the other group, 15 patients, majority of whom were from the Royal Melbourne and the Alfred, and these patients had complex brain tumours. Many of them already had previous neurosurgery performed as well, which may tend to confound some of our observations and outcomes. And you can see here the follow-up period was quite variable in terms of data available to us. So looking at visual acuity, optic nerve sheath fenestrations overall shown to improve visual acuity in the majority of patients, with a total of 27% improving and 59% achieving stability. And these values are consistent with the previous literature. A recent systematic review indicated probably a slightly higher improvement proportion, 44%. We know that 50% of patients achieved a visual acuity of better than 6.6 at last follow-up, and which indicates that it's not only good visual outcomes to stabilise, but also improve visual function long-term. With regards to the other group, the visual acuity either improved or stable except for one patient, which suggests that in patients with non-IAH or venous sinus thrombosis, it can still remain a viable surgical option for sight-threatening optic nerve swelling. And that just breaks down. So at the top, you've got the day that the patient was reviewed. You can also see that in general, patients with IAH had better vision to start with compared to some of the more life-threatening presentations. The trends for the retinal nerve fibre layer thickness, again, with regards to this, we observed trends of improvement between the preoperative and day 360 or more follow-up, both in the optic nerve sheath fenestration group for IIH and overall. And we observed similar reductions in the retinal RNFL thickness in the cerebral venous sinus thrombosis and other groups, indicating a similar effect in these cohorts. One thing I would point out that the rapid lowering of the peripapillary RNFL is somewhat expected, but it also long-term may be confounded by the fact that you can develop optic atrophy long-term. So these are the complications that we observed. Majority were transient diplopia, transient ptosis as well. Note here that the need for CSF diversion therapy was still a small number, and most of these patients that required that were in the other group. So take-home points from this retrospective review. Overall, from a visual acuity perspective, optic nerve sheath penetration improves and stabilizes visual acuity. 50% of patients still achieve a very good long-term vision. Something to point out was that the longer we followed up, the better their outcome was. And also that the worse their mean deviation at presentation, the poorer the likelihood of their visual field improving. So that's probably an important take-home point. Clinically, we find sometimes we delay taking these patients to theatre. And the complications are mostly in the non-IIH cohort, with a third of those patients requiring progression to either some type of CSF diversion procedure. Thank you.
Any questions?
Did you have any patients who had fenestration after VP shunt? So I don't know if I missed that on your slides.
I think there was two patients. So yeah, that's still in that cohort.
And are you seeing a reduction in the number of fenestrations required now? More stenting is being performed in some centres, or are you not doing that in Melbourne yet?
I think that's very centre dependent. For example, at the INDIA, for example, we're obviously an eye hospital, whereas in larger hospitals such as the Alfred or Royal Melbourne, they may go earlier to neurosurgery.
Any other questions? Thank you so much. I'd like to thank all of our speakers for their amazing presentations and sticking to time, and I'd also like to thank our audience for the robust discussion. Thank you so much.